Good afternoon, everyone. You're most welcome to our webinar this afternoon called Place Bonding at a Children's Hospice. And I will introduce our guest speaker, Dr. Helena Dunbar. But before that, I just wanted to welcome our Head of School and Dean of Nursing, Professor Gerard Feely, who is just going to say a few words to open the event. Thank you.
Well, thank you, Francis. It's going to be very few words indeed, but I'm really very, very pleased that this webinar is happening this afternoon. And we're really delighted to welcome Associate Professor Helen Dunbar, who's a very good friend and to the university and our school in children's nursing, and as part of the external examiner, has held an external examiner role for several years. So Helen, you're very, very welcome. I want to say a special welcome to all of those who are involved in children's palliative care and indeed in children's nursing as well, and all of the webinar participants. I see there are 55 already, and that's a great turnout this afternoon. So I'm not going to say very, very much more, but rather to hand you over to Professor Dunbar and to have her. I think, Francie, you're going to do a little short biography first, and then we'll invite Professor Dunbar to start her webinar. So thank you very much again, Helen, and everybody.
Thank you, Professor Feely. Just to introduce Helena, Dr. Helena Dunbar is a children's nurse and an associate professor in the School of Nursing and Midwifery in De Montfort University in Leicester. Her research interests are actually in the areas of paediatric palliative care, place attachment and bonding theory, belongingness and engagement, and caring for children with respiratory and allergic conditions. Helena is a member of the European Association for Palliative Care Paediatric Task Force and Together for Short Lives. Her PhD, which was sponsored by the Rainbow's Hospice for Children and Young People in the East Midlands, explored how parents perceived a children's hospice and how they could be influenced to access services. We're delighted to have her here this afternoon, and her presentation will actually look at some of the results of her study, and she'll also take a closer look at the concept of bonding at a children's hospice. So you're most welcome, Helena. We're absolutely delighted to have you here today. So thank you.
Thanks, Francis. So thank you, Gerard and Francis and Suja for inviting me this afternoon. Now, obviously, I would much prefer to be in person in Dublin, but we're all sat in our own either offices or homes looking and talking through a computer screen in these strange times that we're in. As Gerard and Francis said, I've had the pleasure of coming to UCD in Dublin for the last 3 years now. Well, I missed this year because of COVID. My tenure is nearly over, and I will be finishing in next year at UCD. I've really enjoyed it. I've enjoyed being part of the team, and I just want to thank you all for your warm welcome. You are a lovely team to work with, and I've really enjoyed my time here in Dublin. And obviously, hopefully from my accent, you know I'm not that far from Dublin. I'm sort of a north of the border girl, trained in Belfast, and made my way to England, and to marry a man thinking I'd come back to Northern Ireland, but I'm still in England. So there you go. I've got 3 lovely children, and we do try to get home as much as possible. So as I said, Francis said, my PhD is in children's palliative care. I was very fortunate to be awarded a studentship, which meant that I was able to pretty much do this full time while sort of teaching at the university. And I just want to say thank you to all of those who did support me, and particularly the families that I had the pleasure to work with, really. So let's have a look then at what I did. So my study, I spent a lot of time scoping really and meeting with lots of key stakeholders across the East Midlands and families and children to actually really sort of think about what we wanted to know and what we wanted to do. And these are the things that we sort of decided we would look at, or I would look at. So I wanted to get some kind of idea really what parents thought of existing and potential use of children's hospice services, and sort of working with palliative care teams. I wanted to look at sort of what would entice parents to come and use a hospice, or what would put them off coming to the hospice to use any of the services there, and sort of what were the characteristics of that. So it was, in research terms, it was a qualitative piece of work underpinned by a constructivist grounded theory. Now that all sounds very important, doesn't it? But in reality, it's about talking to families. It's about gathering lots and lots of information and then trying to make sense of all of that data. I did a two-phase study, and so in the first phase I invited parents who currently use the hospice to several focus groups that I was running throughout the region. And the reason for that was, many of you will know that time is really important to these families, particularly when they're really, really busy. And so I wanted to take my research as close to their homes as possible, to try and sort of make life a little bit easier for them rather than having to come to me. And then in phase two, I set out then to invite parents whose child was known to palliative care community teams across the whole of the East Midlands, who didn't actually access the hospice, so that I could have two fairly comparative groups of parents. Now, in terms of sort of inclusion criteria and recruitment to the study, obviously the parents have to have a child with a defined life-limiting condition. Now, I use the Together for Short Lives criteria for that. I'm sure many of you have seen that. There are 4 categories. It's quite an umbrella of various conditions that fall into those various categories, and lots of different terminologies and diagnoses of children really. So it was fairly inclusive. You'll see there, I was able to invite 258 parents into phase 1, 35 accepted, and then for various reasons and children getting poorly, etc., I had 24 who actually attended the focus groups that I ran. Now you're probably looking at that thinking, oh my gosh, that's really small numbers. I think when you're in research, and particularly qualitative research, and particularly research with children and children with palliative care needs, to actually get 24 parents who are willing to talk to you and have the time to talk to you is really encouraging. And then in phase 2, I invited 48 parents, or the teams invited 48 parents that they identified across the region, and I had 14 parents who came and I did one-to-one interviews with them. So representing children then, I had 38 parents in total that I had the pleasure to talk to and engage with. Of 36 children, 8 were dads, which were really encouraging, because sometimes it's often the mums that we get to talk to, but this time I did have some dads come forward, and that was lovely. 6 were from groups other than white British, which again was really encouraging, and 6 were single parents, and we know that for many of these families it's difficult, and sometimes there are marital breakdown, etc. In the families. So that sort of just gives you a little bit of flavour. Going through ethics, etc. was a nightmare, and I'm not going to talk about that. But to get ethics approval across the whole of a big region, East Midlands is quite a big region, and we had 7 teams who were obviously involved in the study, which meant that I had to have approval from lots and lots and lots of different people. So that was a bit of a headache, but don't let that put you off research at all. So I'm going to talk to you mostly about what I found, because that's the interesting bit, isn't it? And what are these parents saying? What do the parents want? And with any kind of qualitative research, you analyse and analyse and analyse for days and days and days and days, in the hope of coming up with some ideas. And so this is all grounded, and that's why it's a grounded theory study in what parents said, and much of the terminology I use has come directly from the parents. And so the three main concepts and themes that I identified were called coming home, this is living now, and moving forward. And I'm going to just talk to you a little bit about some of the things that I found in those three main areas. So the first one then, coming home. So that sort of, the whole idea of coming home represents this sort of desire that parents of these children have to find somewhere which isn't home, but feels like home, and where they know that their child can receive the care and attention that those parents would want for their children. And I think for many of us, home represents a safe place to be. It's somewhere where we feel comfortable, where we feel at home and secure. And for many of these families, that's what they want. They are the experts in caring for these children, and they want their children to be looked after in the same way. But you know what, that's really hard, making that decision to actually leave your home and accept respite or care or short break, whatever term you want to use, from other people is not easy for many of these parents. And many of them talked about how they had to be ready to accept help. And it would be lovely if we could put a tick in a box on the calendar that says on a certain day, after they're diagnosed, parents are going to be ready to accept help. But I think you and I know that that doesn't happen. And they've got to work through many issues before they're ready to accept help, and particularly help from hospice services. And I had a mum who, you know, talked to me about, she'd driven up to the hospice 3 times with her daughter, and sort of got ready to get out of the car and then closed the door again and went home. And that was an example of some of the stories really that parents told, in terms of this constant dilemma that they had about, is it right for me to go to a hospice to get some respite and some help? And alongside that, there were all of these internal battles. That whole battle of, you know, I'm a parent and it's my responsibility to look after my children. That whole feeling of being separated. If I take my child somewhere, you know, will I be separated from them? Can I stay with them? Do I want to stay with them? The whole idea of respite is to give a parent some time, and some time with the rest of their children, the rest of their family. But that comes with a whole lot of guilt. Because it's not normal, is it, for us to take our children to a hospice and leave them there and ask somebody else to care for them. And many of the parents talked about, you know, as an example, for many of us, we would ring up grandma, nana and grandpa and ask them to have our children overnight, or a friend. But in many of these circumstances, that's not possible. The children have too many needs and complex needs that it's difficult for parents to do that. And then the whole identity of the hospice. I wonder what many of you think today when you think about hospice. I don't know whether many of you are from Laura Lynn, or whether or not you've been to see Laura Lynn. I had the pleasure of visiting it last year, and Frances was able to organise that for me. And it's an amazing place, and many of these children's hospices are. And I would encourage you, if you've never had the opportunity to do that, to go along. Because I think when you're informed as a healthcare professional, then that's really helpful for parents, because the whole identity is a hurdle for them. But unfortunately for many of these families, the choice is often taken away from them, because it's this overriding need and desire and crisis for help and rest that often is their final decision. Life is sometimes so hard, or they reach a crisis situation, or their child is so poorly that they have no option but to go to the hospice. And then there's this whole sort of idea about belonging. As I say, when most of us are at home or in different teams or different groups, we want to belong wherever we are. For these parents, it was no different. They wanted to feel a sense of belonging at the hospice. And there were certain characteristics that they described as being really important to them. And this whole idea of safety and security was by far the most important. And many of them talked about wanting to know their child was safe and secure, that they were being looked after by skilled and competent staff, and staff who knew their child and the nuances of their care. And what I mean by that are the important little things for parents. And, you know, I have so many stories of what parents felt was important. And the one that stuck with me, I think, the most was this mum explained how, you know, for years, she had been doing her daughter's hair in a certain way every morning, and she would have put it up in 2 pigtails. And the first time she took her daughter to the hospice and she went to visit her, when she was there, her daughter's hair was up in a ponytail. Now, for you and I, you might think, well, you know, that's great, she was looked after, her hair was done. But for that mum, for years, she'd been putting her hair up in pigtails, and that was a really significant thing for her. So we need to find out, we need to understand what's really important for these families, and those little things. And part of that then will help us as professionals build trust and good relationships with them. And part of that's about continuity and consistency. We all want the same people, don't we, looking after our children. Even in hospital, we want the same nurses looking after us because we get to know them, we trust them. But remember, these families, these parents are the experts. And so we as professionals need to understand what that is. And they want an environment that feels like home. But the strange thing in all of that belonging is there's a real paradox, because actually the reason they're there at the hospice and the reason that they might feel they belong is because of their child's diagnosis, and because potentially they will need end-of-life care. And many families did struggle with that. And this whole idea of the hospice being viewed as having 2 sides to it was remarkable. And I talked about thresholds and crossing thresholds when parents arrived at the hospice, but actually for some of them, there was this concept of there was this inner threshold. And whilst many hospices don't have a differentiation in space between where end-of-life care happens and where short breaks happen, parents in my study viewed it like that. And they found it much easier to agree to come to the hospice for potential short breaks than actually go there for the idea of sort of end-of-life care. And I had some really interesting quotes around this whole sort of disguise. You know, they talked about there's nothing on the outside that really shows what's going on inside. Respite is not the real reason for the place. It actually operates in 2 different ways. It's got 2 identities, but one identity is sat behind the other. They all do a fantastic job in masking the real reason for the place, and you can't see any of it. It's there, but you can't see it. You know, we've been, and one other mother said, we've been there when there's children that only have hours to live, and it doesn't feel like that. So they're really good at hiding what they do. And actually, we don't hide what we do we, at hospices? But that was sort of what the parents perceived, and that's something I really want to look at a little bit more in the future. So then the second theme was around this idea of this is living now. And We know that for many of these families, life isn't what they had planned or hoped for. And when they were given the diagnosis of their child, life for them was shaped in a different way. And many of the parents talked about, you know, how they constantly had to balance the scales, how they were trying to overcome this life of restrictions that they felt they had. And there's much literature that looks at, you know, the difficulties that many families have around resourcing, the intensity of complexity of care, the 24/7 care they do, fighting for every little bit of resource that they get. I'm sure it's no different in Ireland to it is in England. And many of them see this as a constant struggle, and they use many metaphors around being in a battlefield and a battleground, and it's really interesting. And that's not new. We've seen that in much literature over the years. But what was also really interesting was that the parents talked about the impact of loss in their lives. And we know that when you've got a child with a life-limiting or, you know, life-shortening condition, there will ultimately be loss. But parents talked about the loss that they felt in terms of their identity, their social relationships, the future for their child, the fact that they weren't going to likely be grandparents, their child wasn't going to get married, and all of the loss that they were experiencing now as their child was living. And they really talked quite a lot about pre-bereavement, and many of them talked about how they felt robbed, and how they really struggled with this loss in their lives. And at the same time, they were trying to create a normal life, but recognized that their normal was very different from what would be my normal. What was really interesting was that many of them talked about the hospice giving. So the parents that did go to the hospice, they talked about the hospice giving them a little glimpse of normality. Because for those who were able to leave their child there, they were then able to go home and have a little bit of what they saw as normal life. Because many of them talked about the lack of spontaneity that they had. And, you know, so the wonderful thing about qualitative work is you get to listen to, and the pleasure of listening to so many stories. There's so many things I could tell you, and so much rich data. And even after, you know, years of doing your study, you still remember and you can still associate so many of those parents. And many of them talked about the therapeutic effect of normality that the hospice was able to give them, if a lot of the characteristics were there. And so the final theme then was called Moving Forward, and it portrays the idea that living with a child is akin to this journey of uncertainty in terms of prognosis and path, etc. And again, we know that many of these families talk about the journey that they're on, the peaks and troughs that they have to experience along the way, that often there isn't it's difficult. They know that there is a sense of travel. They know that potentially there's an end, but they have no idea when that end of that journey is going to be. And again, we know now in many of these families, these children are living for a lot longer than they would have done 10, 15 years ago. But that in itself actually creates more difficulties for some parents. And again, some parents talked about how, you know, they were really honest and said that, you know, they had some 15 and 16-year-olds, older young people, and they didn't think they would still be there at the age of 16, 17. And so for some of these parents, they had thought that, you know, their child would have died in early teenage life, and then potentially there would be the option for them to continue with their life. And many of them struggled with the fact that their child was still here. And that may sound to some of you really strange, but I think whilst you know, they love their children, absolutely love them. That sense of this journey being much longer now than I ever thought it would be, or that the doctors told me it would be when my child was younger, is really difficult. And of course for us now, that creates a future where many of these children are moving into adult services. So because they're living a lot longer than anticipated, we're now seeing a new generation, aren't we, of young people who need to be transitioned across to adult services. And that's very scary, as we know, for many of these families. Because, you know, to accept help from children's services is difficult. To accept help from adult services that you have no idea about is a really scary thing. And then in every research, there's always some little bits and things that you find that you think, oh, that doesn't quite fit there, or doesn't quite fit. But you still need to report on it. And the bit that didn't sit quite so well with my study, but was really interesting, was the group of particularly young men with Duchenne's muscular dystrophy who were using the hospice for a place to go because there was nowhere else to go. And they went there and to interact with other young men or boys their age. But these are very smart young men, cognitively aware. And yes, they've got lots of physical disabilities, but ultimately the hospice is not the right place for them. But it was certainly in my study the only place that was available in the East Midlands. So when you then sort of are doing a piece of qualitative work, you've got all your findings, you've got to begin to think about how does this all fit together? How does this relate to the literature that's already out there? You know, what's this telling me? And so for me, I then started to look into the literature around this whole idea of parents searching for a place. And you know, lots of complex decision making that they had to do, lots of interrelationships between the hospice. And I started to then look at sort of the whole idea of place attachment theory, and sort of human geography, and this whole idea of what place and space is. I found it really, really interesting. And as I looked more into how we as humans associate different places, this whole idea of place bonding sort of came about, really. And I think, as I said earlier, for most of us, we bond with our home, don't we? That's where we want to be. But what I found was that if there were certain dimensions available, then for many of these parents, going to the hospice, or the thought of going to the hospice, was a little bit easier. And so I came up with this concept, which I'll just talk you through, really. So along the bottom, we've got that wave, where that sort of demonstrates the journey that these families are on. Up and down, those peaks and troughs. We don't know how long it is. For some families, it's short. For some families, it's a long, long time. But the place they want to be is at home. But the journey to sort of reaching out and accepting help begins with that whole a bit of a sense of uprootedness, as parents begin to search for what's around. So in Dublin, what's around for me to access support and help if I need it? Inevitably, that means that they have to take themselves from their home and find somewhere and cross that threshold. And for me, in my study, as they sort of began to search, the hospice was the only place available to them. But there needed to be 5 things available there that made them feel that it was the right place to go. And I'll talk to you about those in a moment. And then ultimately, as that journey gets longer and these children get older, they then need to leave that place that's become familiar to them, the place. And we know that for many hospices, if you're there for short breaks, it's only for a short space of time. You have to then come out of it again and either go home, or if you get to a certain age, you then need to move into adult services. And so there's another threshold to sort of work through. But the 5 sort of dimensions that I sort of found really were, the first one was this sort of sense of familiarity. So when they were looking for a place, these families wanted somewhere, as I say, where their child they knew would be safe and secure, and they would be able to leave them. They wanted, as I say, staff who knew their child, and they wanted their child to be cared for in the same way. So they constantly weigh up the benefits and costs of taking their child somewhere. And the more familiar you become with the place, the stronger sense of belonging or insideness or happiness that you feel. And there's a load of literature around that whole concept of coming home, and for many of us, we want to experience that sense of at homeness. And sometimes that threshold that we have to cross if we enter a new place, sometimes to allow us to cross that threshold, we have to change how we perceive a place. So think about if you were going to the leisure centre or to the theatre, and the concept of how you see that place. Is there anything that would put you off going into the leisure centre? Do you think of it differently? What about going to hospital? Do you think about a hospital appointment differently because that's the only way that you're going to get there? And I think often we negotiate or thoughts and ideas about places so that we can sort of cross that threshold. So place familiarity is really important. The second thing that is really important when we looking at the sense of place attachment and bonding is the whole idea of place identity. Now, as I said to you, there were many negative connotations associated with the identity of the hospice, but there are some positive ones as well. And I think that's something in palliative care that we need to work on. In terms of the terminology we use, I don't think it helps. I think it's confusing for parents sometimes, the way that we talk about end-of-life care, etc. And I think if we can get across to parents what actually happens in a hospice and the kind of environment, the services that we offer, then that will help parents. But what I found in my study was that there was a sort of a drawing in effect, and despite this sort of masked identity that the parents talked about, that whole sort of idea of shelter helped them feel much more at home in the hospice. And many of them, rather than seeing it as a clinical environment, were able to again manipulate their sense of how they perceived the hospice to enable them to get there and allow their child to be cared for and looked after. The third thing then is this whole sense of belonging. And belonging to a place. And as I said to you earlier, these were the characteristics that were fundamental to achieving that sense of belongingness for parents. And I think for any of us, wherever we look after children, if we get this right, then for parents, that will really help in the relationships that we build with them and help them entrust their children to our care, really. The fourth thing I called place association. And that sort of, again, is about the functionality of the place, of the hospice. So does it meet the needs of the parents? What kind of care does it offer? The whole idea that there's actually nothing to fear about this building, and certainly Rainbows, where I did the study, did a big piece of building work after this, where they looked at their their front door, if you like, and how welcoming it was for families, and we did a piece of work around that. And that's made a significant difference to how parents can cross and walk over that threshold. What makes an enriched environment? Parents want noise and laughter and fun, and the hospices do provide that. But for those parents who've never been to a hospice, how do we get them to understand that that's what the hospice offers, and that there will be a sense of normality for parents there? Again, I think it's quite interesting when we think about marketing and brand and the information that we get across to families around what a hospice is all about, really. And then finally, many of my families talked about if all of those things were present and they'd come in for respite, then and they felt that they belonged and that their child was cared for and the familiarity was there, the quality was there, then they truly felt that they had found a place like home. And so they were happy to come back again the next time and the next time and the next time. And then if that next time was for end of life, then that makes things a whole lot easier for these families. So I think being able to offer short breaks is something really important. But I don't know about you in Ireland, but COVID has changed things in the UK, and hospices now, as you know, we're not able to offer short breaks at the moment, and many of the families that we have are struggling with that. And we're also using hospices now more for step-down units for children to get them out of hospital. So if our families aren't getting an experience of what services the hospice offers, how difficult is that going to be if they then need it for end-of-life care? And so, just in finishing then, I think there's something really important about bonding to any places where we go. But I do truly believe that we can help families feel safe and develop strong, effective bonds in a hospice, in a children's hospice. And I think, that place where parents initially dreaded entry does become a normal part of their world. A place where they are happy to go back to again and again and again, and a place where they feel really comfortable to the point where it's really actually quite hard to leave, and that's something that they do struggle with then also. And so, for like any research, you always end up with other questions, and these are some of the questions that I have really. Does the theory of place bonding offer a new perspective in parents' journey to seeking and accepting hospice care for their children? I don't know. I don't know the answer to that. That's something that I want to look at more really. And can this be replicated in other places? Do parents in other areas think in the same way? And does bonding offer some reassurances for the time when end-of-life care is needed? So, as I said, if we get parents to understand that the short breaks model feeds into end of life, would it make a difference in their perception and understanding, and help them see end of life as something that's in a hospice is not as frightening as maybe some of the parents did in the study that I had. So that's all I've got, and we're happy to take some questions, I think. So I'm going to stop sharing this screen.
That, maybe Francis, if I may intervene, just to say a sincere thanks to Helena for an excellent presentation, and you've really taken us really to the heart of some of the experiences of children and the parents in the hospice setting. And your set of questions at the end are very pertinent indeed. And as you rightly say, research will always give rise to other questions. There's no doubt about that. So I really want to say a sincere thank you for an excellent presentation. And I'm going to maybe hand back to Francis. I just snuck in to take your chair there, Francis, just for a second. I've just got to get ready for another meeting at 3 o'clock, so I'm just kind of may have to check out in a little while, but I'll try and listen in for the moment. So thank you very much, Helena. Thank you.
Thanks, Jared.
And thank you, Francis.
Thank you, Jared. Thank you. Hi, Helena. Thanks very much for a most interesting presentation and really thought-provoking findings, Helena. Thank you. I was wondering as I was listening to you actually, and I know the audience have questions as well, but a question from me would be, you mentioned that parents have difficulty trying to make the decisions around a kind of going in to receive hospice care, and you talked about those 5 dimensions. Would you see those as needing to be in place to support parents to make those decisions, or is there anything additional really that they might need?
So one of the things we've sort of started to do in the hospice in the East Midlands, Francis, is try and build up those relationships in the community before the families come in. So we've sort of developed a new outreach model really where and certainly at the minute that's been ideal because of COVID really. And so many of the staff have sort of this family support staff have been going out and, you know, offering just very short sort of help at home, or, you know, just getting to know the families in their home situation, and just begin to build up those relationships, so that, you know, if a family does go into crisis and needs to come in, then hopefully there's someone that they know before they get there. And so that seems to be working really well. One of the other things they did was what some of the families were saying that didn't use the hospice was that, you know, they weren't aware of the services, and so again what they started to do was go out and run some family sessions like on a Saturday morning in like a village hall type thing, so that again some of the local families like a Saturday club would begin to understand what services the hospice did offer, and maybe begin to come into some of the family support groups, etc., that there was. So I think, you know, a lot of it is, I think, to encourage sort of bonding, etc. A lot of it does come back to relationships and belonging and feeling.
Yeah. As a critical core area, relationships, then you would feel, Helena. Did you have come across, for participants who were not using the hospice, for those parents, were there any reasons? You mentioned there that they didn't, some of them didn't have knowledge of the available services, but were there other reasons perhaps why they hadn't opted for hospice care?
Yeah, I think a lot of it was not understanding, and just the fear. You know, many of them, their association with hospice was adult hospices, and therefore a lot of them associated it with end of life. And so for many of them, they weren't there in their journey. You know, accepting that your child has got a life-limiting condition for some families is really hard. And that whole concept of palliative care, what does that actually mean? You know, again, for some families, they don't want to go there because, you know, whilst we as professionals know that palliative care for children starts at diagnosis and parallel plans along with them, that's not what some of the families perceive it as. So there is a fear, and even what I found with some of the parents in the study that came to the hospice, they didn't use the hospice name when they talked to their friends about where they were going. etc. It was something that they didn't readily talk about. So I think there was some fear, lack of information, and they just felt that, you know, they didn't want to accept help just at that point in time.
Yeah, thanks for that, Helena. I'm going to hand us over to Suja Samanadahan, Dr. Suja Samanadahan, and she's going to take us through some of the questions as well, Helena. I just asked the audience actually to type away into the chat, the question and answer box there.
Okay.
And I know, Helena, you'll be happy to answer any queries they might have. So that's great. Thanks, Suja.
Thanks, Francis. Thanks, Gerard, Professor Feely, for being here with us. And Helena, thank you for the wonderful and very meaningful study. Thank you for sharing with us. There are a number of questions in the chat box. Rather than me asking a question, and we had so many chats, so I'm going to hold on my question. We had that discussion before. So I'm going to look in the chat box and see what is, what are the real burning questions from the audience. So first and foremost, I don't have the name, but I'm going to read out to you. So the attendee is asking you a question. I know we talk a lot about parents to being the experts, but do you think we put too much pressure on them to know it all? And that is the no. So what she's trying to ask, can you read? Can you see?
Yeah.
Okay. Maybe I'll leave you to, because that's a big long reading. So I'm going to leave it to you to answer that question, if that's okay with you.
Yeah, when we tell parents that, how do we tell them when they're incorrect with this, with what we might be wrong, without knocking their confidence? I think, you know, inevitably we do, don't we? We do expect a lot of parents at times in caring for these children. I think in an ideal, lovely world, there would be enough resources around to support. And we know that many of these families, you know, mums and dads talk about the whole loss of identity, that they're no longer mum and dad. They become carer, they become a nurse. You know, what some of them are doing at home sometimes is better than what we can provide in hospital. And so, you know, there is, we do put a lot of expectations on them. But then there are some parents who want to do that. There are some parents who are very happy to learn and care for their children and see that as part of their responsibility. That, you know, this is my child and I have the responsibility to look after them. So I think, you know, as healthcare professionals, we can offer just support and help. But if parents at the end of the day turn us down, then, you know, we have to accept that we've offered some support and that they're just not ready to go there just yet. Not sure whether that really, the question's disappeared, so I'm not sure whether that completely understands.
I think you answered that question, Helena. Thank you very much. And the next one, Fiona Wood from Laura Lynn. Fiona is telling us she delighted to hear the finding of your research. What aspect surprised you the most when you interviewed the families? Yeah,
I think Fiona, it was the this whole idea of disguise. I really want to dig into that a lot more. You know, certainly in the hospice that I was working in, there's absolutely no sense of any kind of differentiation in space or anything like that. And I just found it so interesting how parents perceive the building, you know, and I've also had it's been quite interesting. I've had a little look around several hospices since I've done my PhD, and also international hospices. And it's really interesting when you start looking at buildings and how we build hospices from new, what they look like. And I think there's something really interesting about the architecture as well of the buildings that we use to depict the environment that we're portraying, really. And I think that's what I want to dig into a bit more, really, is that whole sort of, you know, is it a disguise, or is it just their coping mechanism? Is it they have to sort of adjust their perception in a different way because it's the only way that they'll cope with that whole association of what hospice is, really? So I think that's sort of what surprised me the most, really.
I know you mentioned about the life uncertainty, so living in an uncertainty, especially with the rare or life-limiting conditions. You see that trajectories varies, and then sometimes they get the diagnosis of first decade of life or second, but the children are living longer with advancement of technology. So
Yeah.
that is something even my own research PhD come across very strongly.
Yeah.
Rare diseases. I was really,
Yeah.
I'm just eating away anyway. So that is lot of stuff to learn. So I'm going to take another question.
Yeah.
So Stacy is asking you, hi Helena, thank you for a great insight to your research. Can you identify from your research which ACT category were more than likely to use a hospice? I know there are 4 different categories from my own experience. I'm just,
Yeah.
so what do you think, Helena? I will leave it to you to answer.
Yeah, well, certainly in terms of recruitment, Stacey, I had representation from every category, but I only had one in category 1, which is an oncology diagnosis. And then mostly it was from sort of categories 2 and 4, so your sort of progressive conditions, etc. But there was quite a good spread, really, as I say, apart from the oncology diagnosis. I think what would be really interesting if I went back now to do it, it would look a little bit different, because there's been a lot of work done around sort of trying to get some of the children with congenital anomalies into the hospice, a big push for neonatal. And I think that would be kind of interesting as well, to see whether or not, in terms of recruitment now, what I would get if I went back.
I think that exactly the question Stacey was asking. The next one, what do you have done anything differently if you were starting out this study again? So you just answered that question again, which is brilliant.
What would I do?
Anything else, Helena?
Yeah, what would I do differently? I'd get rid of gatekeepers, but I can't do that. Unfortunately, as you know, we can't approach families. Ethics committees just don't allow you to do that, and you're relying on professionals to do that. The hospice were wonderful, but when I started going out to palliative care teams and community teams across the region, even though I went and met with every team and talked to them about the study, and they assured me that they had lots of children on their caseloads, that whole process of gatekeeping, I think, as healthcare professionals, it's just a real learning curve, isn't it? We assume that some of these families are vulnerable, and therefore we shouldn't be encouraging them to take part in research. But I didn't have one family who didn't want to take part, and who didn't, I would have said, didn't benefit from being part of this study. And so, you know, I think we need to think very carefully about supporting research and not making judgment calls, I think, without you know, discussing very carefully with families and allowing them to tell their stories. I find that really important. I'm just about to start another study looking at siblings of children with life-limiting conditions, because again, I think there's a lot that we can learn from them, and we're going to do a study looking at their well-being and resilience, and I think that will be really interesting as well. But I know ethics will be really hard to get through, because again, you're dealing with you know, I'm going to be talking to children of children who have got a diagnosis of life-limiting condition, and parents, and yeah, it's hard getting these kind of studies through ethics.
I think that is something very a needed area, because siblings' needs are often underrepresented. You know, there is no real program in place, especially for the community. Even when the child is passed away, what is there out for the siblings? What support system in place to build the resilience or support them continuously? So once that end of life care ends and then siblings are left out by themselves, I think that is very much needed, Helena.
Yeah.
I'm going to take another question. Karen Carr from University Ulster, Northern Ireland Children's Hospice. Parent data, how are you going to use it? Make sure their experience not relevant to the study, not lost. So I may leave you to answer that question, Helena. Is that okay with you?
Yeah, you know, obviously I have published, Karen, and you know, I've presented, and it's trying to get you know, things like today are wonderful, aren't they? Because, you know, it gives you a chance to share your work. And, you know, I think for any researcher working in a small field, it's hard, isn't it, Suja? You know, you try to break into you know, I think if you look at paediatric palliative care per se across the UK and Ireland, there are key places where a lot of research is going, where a lot of money is being invested, and then when you have other areas who, you know, are trying to progress and do their work, it's hard to get funding. And the best way to do that is to pair up with other people and work together. And that's why I said my next piece of work, I've paired up with somebody from mental health services, because I've obviously got an interest in children with palliative care needs. She's got an interest in mental health and resilience, and so we can work together. And so I think, you know, to get information out there, we need to be joining up with Northern Ireland Children's Hospice and doing work together with Laura Lynn and doing work together. And I think the more we collaborate, then the bigger pieces of work we get to do and the more information we get out there. I am really passionate about this area, and I'll talk to anybody. And, you know, I do have ideas to take things forward, and I think you just keep chipping away at it and keep trying to promote yourself in lots of different areas, and put yourself out there.
Thank you, Helena. I think that's very powerful message, because life-limiting rare disease are all very small pool of researchers and cohort. And the funding, you know, as you know, very small sample size, very difficult to get funding, is very important to joining up the dots and work together as a team. And I'm very much with you on that aspect. So I'm going to take another question from Claire Magner, one of our colleagues from ECD. Really enjoying this very insightful presentation, Helena. What are the research priorities now in this area, in your view, Helena? I know you're answering as we go along, but it will be wonderful to hear from you. Another aspect of some priorities from you.
Hi, Claire. How are you? So at the moment, you're probably aware, Lorna Fraser has just completed a big piece of work around sort of epidemiology again, and looking at our numbers. And, you know, we now know that the prevalence of children with life-limiting conditions is shooting up, and is much more now than we thought it was 10 years ago. And they've obviously projected and done a trajectory of where we're going to be. So I think from that, the priorities are education and training, and getting it out there in terms of, so for me, what's really important is making sure that undergraduate nurses, undergraduate paramedic students, undergraduate medical students know some basics and are able to talk to these families, are able to communicate in very simple terms. So a real sort of foundation and understanding of what paediatric palliative care is, because, you know, we have specialists in the field, and that's great, but actually there's an awful lot of healthcare professionals who actually don't have that knowledge base. So I think there needs to be a big piece of work done around education and training. I think siblings is really important, and you know, transition into adulthood, and Together for Short Lives is doing that at the moment. They've put a lot of money into their transition program and what's happening there. And yes, I think for me that's the priorities. I've also got some money, and I'm going to be going to North America looking at pediatric palliative care there, and I should be there now and I'm not because I'm stuck because of COVID. But again, that's about sort of some international collaboration really, and trying to get some work across sort of different networks, etc.
I have another question from Neve McEnany from Laura Lynn. So Neve is asking, she's saying thank you to you, and she said, did families say they would like any additional service or support?
Yeah, one of the things that came out, I think, Neve, was this whole pre-bereavement support, and this whole idea of loss before you actually had lost your child. And I know many hospices are doing that now. But it was actually working with the families through their journey of loss long before their child entered end of life care, really. I can remember talking to a dad, and one of the most powerful things he said that really stuck with me was he talked about they'd got a carer who'd come into the home to obviously help at home with their little boy. And one of the things he really struggled with was he talked about the great relationship that the carer had with their little boy, and had built that up. And he came home one day from work, and he came into the kitchen, and the carer was with the little boy, and he went over to his little boy to give him a kiss, and the little boy pushed him away and kissed the carer. And that really that was just so powerful. And that emphasizes to me that whole identity of parents. And it's wonderful, isn't it, that we can support them and we can give them care and carers to help them, but actually they are mum and dad. And if we put carers into the house, or we offer respite, it should be to allow mum and dad to be mum and dad with their child, and have that time with them. And so that struck a real chord with me, I think.
Sorry, I don't think if anybody has any question, we can take one or two questions before we closing down. I'm just wondering, my own experience, we only have one hospice here in Ireland, and you have so many in the UK.
Yeah.
So, when I did my PhD, and I can hear when families, getting the place. I know we have fantastic work done by Laura Lynn. I have to, I have to acknowledge their hard work. At the same time, we don't have a community children's nurses, and we don't have service like a UK. I know you visited Laura Lynn, and if you want to give us a piece of advice for this side of the country, what would you like to give?
Oh dear, Suja. It's great to have a hospice. It is wonderful, but we do need to reach into families' homes. And I think a community service that allows you to do that is beneficial, and also, when I mean a community service, I mean a service that works across hospital and hospice, and is truly integrated. So if you have a family that goes into hospital, then you have nurses that follow them and support them and work with them, and then if they have to transfer them back to the hospice or the home, they can do that. So I think we need to stop working in silos and actually have proper integrated care systems that actually work together. The other thing that I found really interesting over the last few months, we have a paramedic program, and I manage a team of paramedic lecturers now as well, and that's allowed me to do some teaching to some of the paramedic students. And one of the things that I found really interesting is that for many of them, they have no clue how to talk to children, and yet they are you know, first responders, and they're transferring many of these children. And you know, the students I've talked to are so frightened about being called to a situation where there's a child that's dying, and what do they say to parents, what do they say to the child, how do they deal with that and cope with that. So we need to also be working across professional boundaries, I think, as well. So I think that's really interesting.
And then the current COVID-19 has created a lot of challenges for this family.
Yeah.
I know we are listening to a lot of stories every day, and also my colleague, we have international colleagues from Ryerson University, Toronto, with the sick kids. They are leading out a study looking at the impact of COVID-19 on home care.
Yeah.
So they invited us from ECD and a couple of service collaborators from across the Republic, and they also invited Northern Ireland. So we are excited to be part. At the same time, it's important for us to understand what is happening in our own country.
Yeah.
And then see what is the policy and practice in place and influence the service. So I think there are a lot of work has to be done, because cocooning and shielding is really something, you know, parents are mindful, you know, they don't want to bring any additional members to the family. So there are a lot of work need to be done, is happening. I'm not saying it is happening. So I'm going to take another question here from Kate Coveney, you know, Kate from the team.
Yeah.
So she's saying, thank you so much for the fantastic and insightful presentation. I'm really interested in your focus on siblings, as Kate PhD is focusing on health-related communication with the siblings of children with a chronic illness. Are you planning on completing a MISS method study? And she's also asking another question, any advice in assessing children in the community for recruitment? So...
So what I'm doing, Kate, is actually it's a participatory study. So it's the young people will be pretty much sort of creating the study as we go along. It's all about what we don't want to do is focus on the fact that they're a sibling of a child with a life-limiting condition. It's about sort of you know, helping them to look at what support, what helps them, what works well. It's all about sort of their resilience and sort of welfare and well-being, really. And the whole idea is that, so what we're doing is, again, there's different phases to the study. So there will be some qualitative work where we're going to do some focus group and participatory activities with them, and then we'll co-create a package of care that they come up with themselves. It might be, so say for example they want to develop some kind of game or whatever, then we'll bring people in to help develop that with them. But also we will be collecting some quantitative data in terms of well-being scores, sort of some mental health things, that kind of thing. So there'll be a little bit of a mix, but it will be primarily about the young people creating a package of support that hopefully then we can get a bigger grant and roll it out a bit further.
I think that is so wonderful, because you are bringing the children voice at the heart of the research, and bringing them as a co-researchers will be something really powerful, especially the children's right and children's voice. So finally, I have one more question from Fiona Wood. What would help families in the early days of their journey to understand the concept of palliative care?
That's a real tricky one, Fiona, isn't it? And I'm sure you've got loads of experience, you know, doing that yourselves, really. You know, it's that old terminology, isn't it? You know, what is palliative care? And I think if we get better as healthcare professionals, bringing it in at an earlier stage. I'm sure you've seen the bow that they've done, haven't you, with Together for Short Lives, in terms of parallel planning, where, you know, we focus very much on the disease and the management and the care at the very early stages, but introduce very, very slightly that concept and allow that to grow as the child obviously gets less and less in need of sort of disease management, really. So I think we need to probably get a little bit better at being able to talk to parents, and not to be frightened about introducing sort of concepts at an earlier stage. But again, I think that comes, doesn't it, with years and years of experience. And you know, certainly my thoughts from working in academia is that we're only just beginning to really get palliative care into the nursing curriculum. And you know, certainly when I qualified many years ago, I can't remember getting any theory around how to communicate death and dying. You were thrown into a body, weren't you, to lay out, and that was your sort of focus on death and dying. And I think we need to get, for me, I think we need to be a bit more comfortable about that whole concept of death and dying. And I don't think we are in this culture that we're living in. I think it's certainly in England is a real British culture, and you don't talk about death and dying. Whereas coming from Northern Ireland, it's very similar to Ireland, and you know, we celebrate it in a different way, I think. So it's a tough one, really, in terms of getting families to understand that. But I think it is about communication and relationships and building those at a much earlier stage, and helping them. You know, we can't go in there sort of talking about palliative care straight away, because they won't understand it, and that will really freak them out and scare them off. But it's about support, isn't it, and where they can get support from, I think.
Thanks, Helena. We do have a informing families a kind of guidelines for Ireland, and that been used very widely across many practitioners. Again, I know sometimes, you know, people are not really strict. You know, when you look at the literature, you can see there are still the communication is varies, especially, you know, when have the new diagnosis of a rare or life-limiting condition, how we communicate with the family. Yeah. That is another challenging issues. So I'm going to take one more question. Karen Carr, fabulous work. I love that you changed the entrance to rainbows in response to your finding. Was this difficult?
Well, I didn't change the entrance. The the builders and the architects did, but yeah, it was. No, it was actually something the board took on really readily, Karen. There were so many families talked about how they hated the doors and the entrance, and you walked in and there was like a bit of a foyer, and you were sort of in a reception area, and there was very little room for, you know, wheelchairs and everything. It wasn't very bright, and so I think the board took some of those findings on quite readily, really, from the families, and so they were quite happy to sort of look at that and other things. And the other thing that one was really interesting was, so I did this at Rainbows in the East Midlands, and when you ring them up, their phone line always played Somewhere Over the Rainbow. Oh, and then so many families were saying that did their heads in, you know, that song, whoa, the rainbow. And it was just so serene, and they didn't want that. They wanted to be able to ring up the hospice and have some real funky music, or, you know, some up-to-date stuff. And but they didn't so readily take that on, I have to say. They haven't. I'm not sure they've changed that yet, which is such a shame, because that's certainly what one of the families said. Kate, I'm just thinking I didn't answer your question about advice in accessing children in the community for recruitment. I think that's a really difficult one, because you've got to go through gatekeepers, and it's about working with your gatekeepers, whoever they are. This study that we're just about to start, and before we did anything, we brought all our gatekeepers in and we met with them, and we've brought them on board, and they've been very much part of it. And I think if you give them ownership and part of the study and being involved in it, they're more likely to talk about it quite openly to parents. So I think that's what I would suggest, is get your gatekeepers on board.
Okay, so I'm going to hand over to, thank you so much, Helena, for spending time with us today. So I'm going to hand over to Francis, and lovely to see you.
Yeah, lovely to see you,
Talk
Suja.
again. Thank you.
Bye.
Bye-bye.
Thanks, Suja. Well, I'm just going to wrap it up really for this afternoon, but just to say a huge thanks to you, Helena. It was a most enjoyable, informative afternoon. I loved hearing about your research, and the response there from the audience. Lots of relevant questions indicates, I think, as well, that they really enjoyed it. So, and the best of luck now with your extension looking at siblings, because that sounds very amazing. Using participatory health research methods as well sounds wonderful. So we look forward to hearing more about that in the future, Helena. And thank you again for your time. And yeah,
that's fine.
Sorry, before we go, I just want to say thank you to all the participants. You spent almost an hour with us. And thank you so much. I know we can't see you, but we know you are hearing us.
That's true.
And thank you so much for spending time with us. Hopefully we'll have more webinar series like this.
Yeah.
I would also like to thank Justine for organizing and facilitating this section. And thank you, Justine. And thank you, everyone. And
thank you, Suja.